Specialty Stories, session number 67. Whether you're a pre-med or a medical student, you've answered the calling to become a physician. Soon you'll have to start deciding what type of medicine you'll want to practice. This podcast will tell you the stories of specialists from every field to give you the information you need to make sure you make the most informed decision possible when it comes to choosing your specialty. Welcome to Specialty Stories. My name is Dr. Ryan Gray, your host here every week. Now, if you're a pre-med student, you should definitely be checking out the Pre-Med Years, which is my oldest running and biggest podcast, covering test prep, covering applications, essay writing, personal statement writing, covering interview prep, and so much more. Go check that out at premedyears.com. If you're a medical student, you should be telling all your pre-med friends to go check out the Pre-Med Years. This week, I'm excited to talk to an academic emergency medicine physician who actually has a subspecialty in wilderness medicine. Now, we don't go into a bunch of wilderness medicine because it's really not that big of a practice to talk about in its own specialty stories, but we do talk about it a little bit. But we do talk about academic emergency medicine and why this physician chose academic emergency medicine. Now, if you've been listening to the podcast for a while, or even if you're new, if you go back to session 2, we covered emergency medicine from a community perspective. And in that podcast, we had Dr. Freese on talking about community-based emergency medicine. This week, we have Dr. Reno on, Dr. Elaine Reno, talking about academic emergency medicine, why she chose emergency medicine, why she chose academic emergency medicine, and much, much more. Elaine, when did you realize that emergency medicine was what you wanted to do with your life?
So when I was a third-year student, I did all the rotations, and I just liked all of them. And at the end of the day, the two things that interested me the most were EM and actually OBGYN. And I think they're actually pretty similar. It's 90% routine and 10%, acute crisis, and then 90% routine and then 10%, acute crisis and, it's hitting the fan for lack of a better word. And I was drawn to both, and I went back and forth. And fundamentally, I realized, one, OBGYN, they primarily see adult women, and I didn't want to stop seeing children, and I liked sort of the variety of emergency medicine. And I also don't like the operating room very much, and so I thought, even if I end up doing primarily labor and delivery, I still have to do the gynecology training. So
you mentioned the 90%, 10%. I think a lot of students who think about emergency medicine think about the just pure adrenaline rush all the time, gunshot wounds, stab wounds, all of this. How much of that is your day? I mean,
there's usually a couple real sick patients every day that it's sort of the adrenaline rush, they're real sick and you're dealing with that. But a lot of emergency medicine is, most chest pain is not heart attacks. Most car accidents, the people are fine. Most, weakness or tingling sensation is not a stroke, which is good, right? Because we don't want everyone to be sick and dying all the time. But a lot of my day is much more routine, I think, than most people think.
What do you think what traits make a good emergency medicine doc?
So I think the first thing is humility. So you in the hospital, you're always going to need help. You're always going to need to talk to your specialty consultants, and they're always going to have they're going to have more information about a specific disease if they're a subspecialist. And so you have to be a good communicator. You have to be able to work with your specialty consultants. You also, emergency medicine is an extreme team sport. I think honestly more than any other medical specialty. And so you have to be able to work in a team with nurses, with the techs, with radiology. It's just very much a team game, and you have to be able to do that and do that well.
Why do you think it's more than other specialties?
Like when you're on inpatient medicine wards, I feel like you rounded and then you placed orders. And you sat in one area and the nurses like sat at the nurses station. It's not really like that in emergency medicine. Like you're, in a room with a critical patient and everyone sort of has a different role, and your job as the attending is to sort of make sure everyone's like, um, you know, like able to do their role, and then taking all the facts you get from everyone, like the information the nurse is giving you and the information the patient's giving you and the information, respiratory is giving you, and put it all together and try and sort of come up with what's going on with this patient and how you want to manage them. And it's just much more like I say like we're much more in the trenches with the nurses and with the techs and on a day-to-day basis.
On a day-to-day basis, what sorts of patients are you typically treating in an emergency room?
So, we see everything, like anything and everything can walk in the front door. I think the common things we see are sort of more common chief complaints, right? Like it's been flu season, so we've seen a ton of the flu. We've seen a ton of respiratory illness, the chest pain, abdominal pain, headaches. That's kind of like the bread and butter of emergency medicine. And it's your people come in with symptoms rather than diseases. And it's your job to figure out what's going on and what you need to do to manage it.
Describe a typical week.
Mm-hmm. So my schedule varies every single week, which some people would hate that. I really like the variety. So like, if at Tuesday at noon I'm like taking a nap, that's totally okay, because maybe last night I worked an overnight. I worked Monday 11 p to 7 a.m. So every week the schedule is different, and I like that a lot because I just like variety. Some people will probably hate that. And then what comes into the ER, my job as an ER doc is like I say it's like to man the doors of the emergency room. And so for the next 8 hours, I'm the person who's standing there in front of those doors dealing with everything that rolls in, whatever it is, whether it's a stub TO, whether it's a heart attack, whether it's a stabbing, whether it's a shooting. And every day, we get a variety from chest pain, from heart attacks, from, strokes, from trauma patients to, cancer patients with infections to, patients having miscarriages to patients who, need a little bit of a workup and are absolutely fine to, broken bones. There's just an extreme variety on a day-to-day basis.
Now, you work in an academic setting. What was the decision algorithm for you to choose academics over a community-based or private practice-based emergency medicine position?
Yeah, so most of my friends went into private practice. For me, academic had lots of draws, some of it being the teaching aspect of it. So I like working with the residents. I teach a class for undergraduate students. And I liked teaching the course. I just liked the sort of academic flavor. Like there's constant ongoing learning every single day. I feel like it challenges me every day to learn more and to be a better doctor. The residents are wicked smart. And they know lots. And, if you don't keep up, they're going to keep you on your toes. And so I just liked the environment of, learning and education that comes with academics. And so that's what I knew, and that's what I stuck with.
Now, you mentioned the operating room earlier. You were talking about OBGYN and operating, and you weren't really sure you liked the operating room. But having that kind of in the back of your mind, it makes me assume that you liked a lot of the procedure aspect of it. For somebody who is thinking about emergency medicine but doesn't like procedures, maybe isn't confident in their ability with them or just doesn't like them, is emergency medicine a good fit for somebody like that?
So I think it depends on so we definitely do a lot of procedures, but we're not like surgeons. We're more like intensivists in the level of procedures we do. So like gastroenterologists, cardiologists, these people do much more procedures than us. Family medicine docs probably do less. We're certainly not surgeons, but we do, central lines and arterial lines and occasionally chest tubes, and we do things like intubation. I think if you really liked the flavor of emergency medicine, but didn't like the big procedures, you could do something like urgent care, although you're still going to be doing things like suturing and splinting. But there'd be an avenue for that. Although if you just hated procedures, this is probably not the specialty for you.
What does call look like as a EM doc?
Yeah, so that is lovely. So we have sick call, which just means a couple times a year if someone is sick, like there's someone to cover their shift. But other than that, when I leave the hospital, like I don't have a pager. I don't have a cell phone with me. Like, if I'm on shift, I'm on shift. But if I'm not on shift, like I'm, you know what I mean? No one calls me to ask me about patient care duty. So I like that aspect of it a lot.
What does the shifts look like? So I've talked to some emergency medicine docs that say, oh, it's this number of shifts is full time. What does that look like for you in an academic setting?
So it is different for every doc in every clinical practice. We work a certain number of shifts based on whether we're full time and what our clinical buy down is to do other things, right? So we get what's called clinical buy down. So you work less shifts to do other things. So if you're doing research, for me, it's education that I get clinical buy down from. But if you're doing research or things like that, you can work less clinical shifts to have time to do that. And that's a huge perk of emergency medicine, but specifically academic emergency medicine. If you have like research interests and you want to do lots of research, but you still want to be a clinician, you just work less clinical shifts. And so I think that's, it's much more like choose your own adventure, I guess, and it's much more amendable to that because you don't have a patient population, like a primary care doctor that you have to see in clinic, things like that. So.
Do you feel like, so this is a two-part question, do you feel like you have enough time for family life outside of the hospital? And because you mentioned the shift work and the variability, do you feel like the time that you do have outside of the hospital is quality time?
So I think that's a great question. So I just had a baby. He's 9 months old now. And so when I got pregnant, I was forced to step back a little bit because the pregnancy was just really difficult. And then I feel like I have enough time with him on a day-to-day basis. And I do some things like, I spend a bunch of time in the office on Tuesday and then I work a clinical shift. So I'll have like a whole day where I don't see him and he's not with me, but then I have the next day off on Wednesdays to just spend time with him. And so I do feel like it's actually very conducive towards a family life. You have to be creative about how you make it work. But I definitely think specifically emergency medicine is very conducive towards a family life. And if you felt like you were working too much and didn't have enough time with family, like it's possible to step down, like not to work full time, to work part time, especially in this specialty. And then in terms of quality time, I think it's about just making quality time. So as an ED doc, like I will always work nights. I will always work weekends. I will always work holidays. Like someone has to be in the ER on Christmas and on Thanksgiving and on New Year's. And that will be a part of my job for the rest of my life, which I'm okay with it. So the time when I'm with my family, we try and like turn off our phones and prioritize being together. And, sometimes we celebrate Christmas on Christmas Eve and sometimes we celebrate Thanksgiving on, the day after. And sometimes I'm at work and, I celebrate Thanksgiving with my work family. So, but it's just, there's upsides and downsides. So,
yeah. What does the residency path look like to become an academic EM doc?
So the emergency medicine is a 3 or 4 year residency, depending on where you go. Most of them are becoming 4-year residencies. And most people who go into academics usually go to a 4-year residency, although, there's no like hard and fast rules. And so the first year is usually, you rotate through a bunch of different specialties. You're like learning a little bit of everything. And then you start to spend more and more time in the emergency room as you progress through your residency training.
How competitive is emergency medicine?
So it's getting more and more competitive, I think, because um, it's conducive towards, having like a good quality of life and having other interests. And so every year it seems like it gets more and more competitive. So we'll see where it kind of falls out.
Yeah. What should a student you've been involved in the admissions side of things for the emergency medicine residency? What should a med student be doing to be competitive to match into emergency medicine?
It's kind of the whole package. I think probably the whole package more in EM maybe than in other specialties. But so obviously we want students to have good grades, right? You want to be getting good grades. This is a specialty where I feel like how you work clinically is really important. So you really want to excel in your clerkships. You really want to do well, not just like in the one subspecialty you want to go into, but in all of your clerkships, you want to do well. And then I think we tend to look for well-rounded people. So, we look at your extracurriculars, we look at your research, we look at your letters of recommendation, things like that.
How much bias do you see towards DOs who want to go into emergency medicine?
So that's an interesting question, and you probably know more about this than I do, but I think the DO-MD match is like becoming one soon, which I think is the right call. So I work with DOs. There are DOs in my practice with me. We have DOs that are residents. I think there used to be a greater bias. I think it's slowly fading away. A DO is still like an American medical school. And if the match merges, I think that's the right way moving forward. I think there'll still be some inherent bias at some places, but I don't feel like that's really a big thing where I'm at or in our residency program.
Once you finish your residency training in emergency medicine, are there any opportunities to subspecialize as an EM doc?
Yeah, so there's fellowships in emergency medicine, and there's a bunch of them. So you can do toxicology, you can do global health, you can do admin, you can do education, you can do ultrasound. I did wilderness medicine with a little flair of global health, and so the ability to pick a fellowship is sort of depending on if you want to do it. Most people do not, which is fine too. So.
Let's talk about that for a second, because fellowship training to me, it's like if you're an internist and you go on to do fellowship training in GI or whatever, you're going to see GI patients all day long. But as an EM doc, you don't know what's coming in, and you don't have a clinic for patients to come in. So what's the goal of a student or a resident at that point to go and do fellowship training?
So it depends on what fellowship you do. So a lot of people do fellowships and end up in academics. So like if you do an education fellowship, you end up, doing education work, like whether that's residency director or working with medical students. Toxicology is they take their boards in toxicology, and then they tend to be a consult service. And so like we have the Rocky Mountain Poison Center, and they staff the poison center, and then for patients who overdose or, whatnot, they're a consult service. And actually they consult all over the hospital and often in the intensive care units. With my fellowship, I did a diploma in tropical medicine and hygiene through the London School of Hygiene and Tropical Medicine. And so afterwards, I worked part-time in a travel clinic. I do like pre-travel advice and coordination. It's like a family travel clinic. It's me and a pediatric infectious disease doc. And we work together to kind of provide care for the whole family. And so that is one thing that I do with my fellowship. Most people who do a fellowship, it gives them, it's like they're an ED doc, and then it gives them something else, right? So instead of, having your 14 shifts a month in the emergency department, you're doing X number of shifts, plus you're doing tox consults, or, I'm doing travel medicine. So it just gives you sort of something else to kind of branch out.
What do you wish you knew, the primary care docs, the future primary care docs that are listening, what do you wish they knew about your job in the emergency department and emergency medicine in general to help their future patients?
So I'd say that probably the most important thing, if you want to send a patient to the emergency room, is communication. So, we don't always know why you send patients in, and what your thought process is. And so we have what's called the doc line. So any doc can call in and talk to a doc on call in the emergency room or on staff in the emergency room and talk about why you're sending the patient in and kind of what you want done. I think the most important thing is coordination. So, and it goes both ways, right? Like if you want to send someone into us, call and let us know kind of what you're thinking and then provide contact information, and we can talk to you about, we did this workup and here's what we were thinking, and here's what we found. Because a lot of times emergency medicine is like, it's a stop point in time. Like I'm treating the acute exacerbation of your COPD, or I'm treating your diabetes when you end up in diabetic ketoacidosis. But I'm not going to be managing this long term. And so I think it's, the best thing is sort of cross-specialty communication like that, and that provides the best care for the patient. And I often say to patients, look, you have belly pain. Here's the testing I did. I don't think it's appendicitis. I don't think it's your gallbladder, but I want you to continue the workup with your primary care doctor. And so we often send patients out to say, follow up with your PCP and, continue the ongoing testing.
Yeah. And if things get worse, come back and see us.
Yeah. If things get worse, we're always here.
Yeah. What other specialties, if any, do you work the closest with?
So we work very closely with trauma because under certain criteria, the trauma team comes down to the emergency room for depending on what the trauma is. So I feel like that's when we work closely with. We work closely with cardiology. I think we work closely actually with a lot of specialties, really. Probably the intensive care units, because you're transitioning critical patients from the emergency department to the ICU. So
what special opportunities are there outside of clinical practice, clinical medicine, is there for EM docs?
There's education. People do education work. There's research. There's ED docs that, are full-time researchers. And, one doc I can think of, I think they only work 4 clinical shifts a month in the emergency room, and they do the rest of the time doing research. You can do administrative work at kind of whatever level you want. I'm trying to think what else. Oh, there's ED docs are often emergency EMS directors, so you manage an EMS system and you're the medical director for an EMS system, so like an ambulance group. So I feel like it's pretty variable depending on what your interests are.
What do you know now that you wish you knew before going into it?
I think I wish I knew how much it would affect my sleep. Like the rotating schedules are brutal on your circadian rhythm.
Yeah. And
I would have still picked it, but I don't know what I would have done differently. Maybe I would have started taking melatonin earlier.
With data that we have that shows that shift workers aren't the healthiest and they have increased risks of different conditions and diseases, how does that play into your advice or your love of the specialty and your advice for others to go into it?
I just try and ignore that data that says I'm going to be less healthy because of my job. Does that count?
Yeah, that counts. Data only counts if you read it.
Yeah, if you just put your fingers in your ears and go la 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 la, then it has no application in your life.
Yep. Okay. What do you like the most about being an emergency medicine doc?
I think I like the variety. It's just it's always different. It's always something new. Like if I was a 9 to 5 in the clinic, I think, I don't know, I feel like maybe I would get bored. I just like the variety.
What do you like the least?
The least I like the circadian rhythm disruption.
Do you see any major changes coming to the field of emergency medicine that are important for somebody who may be interested in it in the future to know?
I think and I'm not like in any way a Medicaid or Medicare expert, but I think there's there's a greater and greater goal of keeping patients out of the hospital and figuring out, like, do you really need to be admitted to the hospital? And so we try and kind of work with all of our resources. Like, we have social workers, we have physical therapists, we have mental health counselors, like all these different resources in the emergency room, trying to see, we have case managers, what we can do to, like, keep patients at home and keep them at home safely. So I think that's like a growing field. Like, the example I use is my grandma said when she had her baby, she was in the hospital for like 10 days. I had a C-section and I was in the hospital for 2 days, or the push to, like, keep patients out of the hospital and away from hospital-borne illnesses and away from the complications that come with hospitalization is definitely there. And so figuring out what we can manage at home versus what really has to be admitted is sort of an ever-moving target.
I had a conversation previously with a community-based emergency medicine doc, and we got into an interesting discussion about emergency room utilization for things that aren't emergencies, and how there's possibly a discussion out there that some emergency rooms, some EM docs think maybe we should just take on kind of that primary point of contact for people who are ill, instead of calling and trying to get a same-day appointment with their primary care provider, just going to the emergency room and dealing with that and knowing, hey, it's not an emergency, but we're here for you anyway. Is that sort of discussion going on in the academic world at all?
There's a governing body, the American College of Emergency Physicians, and one thing they're protesting against right now is it's Anthem, I think, Blue Cross Blue Shield, who is in some states now is using discharge diagnosis to deny payment. So if your discharge diagnosis from the ER they feel is not an acute life-threatening emergency, then they'll deny payment. And I'm in no way an expert in this, but that's something ACEP is really advocating against.
Yeah.
I think, because it's just really unfair. Like, how do you know if your chest pain is a pulled muscle versus a heart attack until you come in and get it checked out?
Yeah.
And it's unfair if it turns out to be a pulled muscle that your insurance won't pay the bill, and if it's unfair if it turns out to be a heart attack and you were worried that your insurance wouldn't pay the bill and you'd lose your house, so you sat at home having a heart attack. You know what I mean?
Yeah.
I think, like, in an ideal situation, everyone has a great primary care doctor that they can trust, and that they can call and get access to, like, continuity of care. People come in all the time for things that are urgent but maybe not emergent, and I guess it doesn't bother me. Like, that's what we're there for. If I tell people, like, an emergency is different for everyone. Some things are an emergency for everyone, like your big heart attack, but maybe you're on vacation and you've been saving for this vacation for like 20 years and your kid comes down with strep throat, right? Like, this is an emergency to you and you're not going to wait 2 weeks to get it checked out. So
yeah, that makes sense. If you had to do it all over again, would you still be an EM doc?
Yeah, I love my day-to-day job. I think it's tons of fun. I would definitely do it. I would just, in med school, I'd focus more on wellness. So,
for the pre-med student, med student listening to this now, what last words of wisdom do you have for them so they can start exploring this and see if it's right for them?
I think medicine is a great profession. It is a ton of fun, but it has to be what you want to do. So at 2 a.m. on Christmas morning, the person answering the pager is going to be you. So make sure it's what you want, right? Like, make sure it's not familial pressure or friend pressure or, spouse or significant other pressure. Like, at the end of the day, you're the one doing this. So make sure you're pursuing something that you want to do. And if you don't know or you're not ready yet, then just don't apply. Like, take a year off, travel, work. Medicine is a marathon, and it is like the longest marathon. It is not a sprint. It doesn't matter if you start med school when you're 22 or 25. It doesn't matter if you're a cocktail waitress for a while in there. Like, make sure it's what you want to do, and make sure you take the time to make sure it's what you want to do. So that doesn't matter if you take a year or two off. to decide, or 5 years off. Make sure it's the right choice.
All right, there you have it. Again, that was Dr. Elaine Reno, academic emergency medicine physician here in the Colorado area, in the Denver area, at the University of Colorado, where I happen to be a faculty member as well. So if you're interested in emergency medicine, now you have the comparison between academic emergency medicine, which is this episode, and session 2, where we talked to a community-based emergency medicine physician. Now, hopefully, those two discussions will help you understand some of those differences, some of the similarities, etc. If you have a suggestion for a person, a physician you would like, or you think would be a good guest here on the podcast, shoot me an email, ryan@medicalschoolhq.net. Ask your friend, your father, your sister, your brother, your mother, if they are a physician, if they want to be on this podcast. Ask them to be on. Shoot me an email with their contact information, and we'll try to get that scheduled. Hope you have a great week, and I hope to see you here next week for another episode of Specialty Stories.